Further debate. Gentleman from 15.
Thank you, Mr. Speaker, to debate the bill.
Gentleman has the floor.
Hope you'll indulge me. I've got a little bit of laryngitis today. Maybe that's to your benefit. I won't speak as long.
You said what we were thinking.
When I was a little tyke, my parents would read me bedtime stories. And some of those stories were about Brer Fox and Brer Rabbit. Now, one of those stories, Brer Fox actually caught Brer Rabbit. You see, Brer Rabbit was out, and he always liked to go hopping down the trail, talking to everybody, talking to Mr. Blue Jay and Mr. Frog and all the folks he met along the way. Well, one day, Brer Fox, he figured out a plan. He found himself a bunch of tar, and he made himself a tar baby out of that tar, made it into a human-like figure, put some clothes on it, and up hops Brer Rabbit. And in his normal talkative way, he starts talking to the tar baby. He says, "Hey, how you doing today?" And no answer. "Come on, don't you want to talk?" No answer. So Brer Rabbit got a little excited, and he pushed him. Well, that was the first mistake, huh? So Brer Rabbit, he got caught, and then he put his other paw in there and got stuck too. Pretty soon he's kicking with both feet, and he's all tangled up in the tar baby. Well, this is what we've got here. We've got ourselves a tar baby. And the good gentleman from 27, when he was talking about his conversations with the representative from HHS, they didn't know a lot of anything about anything. I sat through 5 sessions on the Governor's Advisory Committee listening to all the information this last summer. One of those occasions we had representatives from the federal government on a phone conference. Same thing. Couldn't answer us any specific questions about cost, about readiness assessments, a lot of different things that they didn't have an answer for. So if they don't have an answer, how do we expect to have an answer to implement this exchange when the rules keep changing? Now, let's talk about rules a little bit. In the exchange regulations, it says that the federal, I'll just indicate that in CFR 155.105B1, it says the exchange must be able to carry out the required functions of an exchange. The exchange must be capable of carrying out information reporting requirements. The state must elect to establish an exchange by submitting a blueprint in a form specified by HHS. We finally did that. The HHS kept moving the date. Said, "Oh, you have a little more time, have a little more time." Well, why is that? Because they want us, they need us to do what they don't want to do themselves. They want us to be mixed up with the tar baby. States seeking to operate a state-based exchange or electing to participate in a state-based partnership exchange, state partnership exchange must submit a completed exchange blueprint no later than 30 days prior to the required approval date of January 1, 2013. Well, we did that barely. But another key part of this was that the state must demonstrate operational readiness to execute the exchange blueprint. And the readiness assessment is conducted by HHS. What does that mean? Basically, it means that your exchange is ready to go, ready to operate, readiness assessment. So I asked during the summer this gentleman from HHS, well, so where's the federal government on their own readiness assessment? Well, I don't know, I can't answer that. I don't know where we're at on that. So the law states that if you haven't submitted your blueprint and you haven't completed your readiness assessment, then you will, and that's by January 1st, 2013, you will have a federal exchange. You lose the state option. So why are we still talking about this? Well, there's a conditional approval that we got, and that gives you a little bit of time. But what does that conditional approval mean? Under the law, the conditional approval, it says, will be granted to those states that do not meet all the exchange approval requirements on January 1st, but are making significant progress and will be operationally ready. I'd like to know what, other than submitting the blueprint, what significant progress we have made. The point is that the federal government keeps changing the rules, and that's exactly what we face with this exchange. We don't know where it will end up in the end. Well, what about this tar baby? I've got the CFRs here, and I'd like to read just a couple of parts of it. Functions of the exchange. Let me go back one here first. Section 155.120, non-interference with federal law and non-discrimination standards. An exchange must not establish rules that conflict with or prevent the application of regulations promulgated by HHS. Pretty straightforward, pretty clear. How much wiggle room does that give us? How much control? 155.200, functions of an exchange. It's interesting what's packed into just a few paragraphs here of what has to be done. Number one, there needs to be oversight and financial integrity. Thank you. The exchange must, that helped. The exchange must perform the minimum functions described in this subpart. And subparts D, E, H, and K. Well, what are D, E, H, and K? D is eligibility determination. Eligibility for what? Eligibility for Medicaid, eligibility for receiving the credit to receive your premium assistance. What's E? E is an enrollment of applicants. That covers all of the information collection, processing. What's H? That's the shop. We haven't even talked about shop. That's the small business exchange that would be part of this. E, there's certification of plans. Of course, that's your qualified health plans. And make sure that they fit the Obamacare model, that all the plans have the mandatory coverages, that they comply with the requirements of the different metallic plans, bronze, silver, gold, platinum, and otherwise comply with the Obamacare mandates. So how much control does that give us? Okay. Let's talk about consumer assistance tools. A call center. Exchange must provide for operation of a toll-free call center that addresses the needs of consumers requesting assistance, meets the requirements outlined. B, internet website. The exchange must maintain an up-to-date internet website that meets all the requirements of paragraph C. Provides standardized comparative information on each available qualified health plan, including at a minimum, premium and cost sharing information. What's cost sharing information? That's all the credits, the premium subsidy that we've talked about. Has to have all that working through this portal. The summary of benefits and coverage is established. Identification of whether the qualified health care program is a bronze, silver, gold, or platinum level. Number 4, the results of the enrollee satisfaction survey. There's supposed to be a satisfaction survey that's incorporated in all of this as well. Quality ratings assigned, medical loss ratio, transparency of coverage, provider directory, publishing the following financial information, average cost of licensing required by the exchange, regulatory fees required by the exchange, payments required by the exchange, administrative costs of such of the exchange, monies lost to waste, fraud, and abuse. Boy, that's going to be easy to track, isn't it? Provides applicants with information about navigators. We'll talk about that in a minute here. So this isn't just a simple go on the website, plug in where you want to get your airline ticket to. It's going to be processing all of this information, which means we're responsible as a state, as an exchange, that all that is processed correctly. That takes a lot of software, a lot of bugs that are in a system like that. What's next? Well, you need to have an available electronic means calculator to facilitate the comparison of available qualified health plans after the application of any advanced payment of the premium tax credit and the cost sharing. So what does that mean? Well, you put in all your health care information, you put in all your income information, and it figures up what your taxes are going to be, see if you get a credit or not, and then it applies it to all of the different plans to see what credit you might get. That's a pretty complicated program. Doing real-time taxes. My accountant can't even do mine at the end of the year because the rules keep changing. To have a real-time tax calculation, that's a challenge. So what happens if they get it wrong? Well, you know what? They'll come and get you. It's a clawback. If it gets figured wrong and you get too much of a premium credit, well, you'll have to pay for it later. And they want us to do that through our state exchange. They want us to do that. Okay, here's another one. Accessibility. Information must be provided to applicants and enrollees in plain language and in a manner that is accessible and timely. Well, that seems pretty good. But it says here, individuals who are limited English proficient through the provision of language services at no cost to the individual, including oral interpretation, written language, translations, taglines in non-English languages. Well, how many languages do we have here in Boise? We have a lot of refugee groups here in Boise. Of course, there's Spanish. We've got different African dialects. We got Arabic. We got Russian. You name it, we got it. But that's what it says. Doesn't limit it at all. It says individuals who are limited. That's one person. Individuals who are limited English proficient through the provision of language services at no cost to the individual. Who's going to pay for that? We all will. Consumer assistance. Here's another. These are all musts. The exchange must have a consumer assistance function that meets the standards, including the navigator. And we'll get to the navigator here next, except that it says here outreach and education. The exchange must conduct outreach and education activities that meet the standards. Well, what does that mean? In this body, we've had debates here for a number of years about outreach concerning Medicaid. Do we spend money to go out and get people to apply for Medicaid, or we just let them figure it out and do it themselves? We've resisted that type of outreach. But here it is, we're bound to it. Navigators. General requirements. The exchange must establish a navigator program consistent with this section through which it awards grants to eligible public or private entities. Okay, so now we become a grant administrator. The exchange has to identify who these navigators are and give them grants. Where does the grant money come from? Well, they don't get paid like brokers do through premiums because they're not supposed to have a financial interest. So that's why it's a grant. So this exchange organization is now running a grant program through whatever fees they can assess through the exchange. Speaker would allow, I'd like to read from a couple of news articles about navigators and challenges thus far.
Without objection.
Thank you, Mr. Speaker.
Gentleman may read.
This is from Health Policy Solutions. It says, Health Exchange needs an army of navigators to aid customers. Colorado's Health Insurance Exchange has morphed from a Travelocity-style self-service website to an online interface with in-person navigators slated to help hundreds of thousands of customers choose from an array of complex health plans. The most vexing questions are if there will be enough navigators who will pay them to avoid conflicts of interest. New surveys of potential health exchange clients released Monday found consumers want simple TurboTax style guidance, help from people in their communities whom they trust, side-by-side comparisons of complex health plans. Thought that's what brokers did. But doubts are surfacing, however, about how exchange managers will be able to create this system by October 1st, how they can avoid having navigators or health insurance brokers steer clients to plans that financially benefit the workers or health systems they represent. Jim Reisberger, Colorado's Commissioner of Insurance, said during an exchange board meeting Monday that building such a large customer service force will be a massive task. Reisberger calculated that in order to enroll the anticipated number of clients, the state will need enough navigators to enroll 800 people per day, 24/7, for at least 6 months. That's a lot of navigators. Where are they going to come from, says Reisberger. That's their insurance director in Colorado. Another article indicates that Arkansas plans to hire about 535 workers. California plans to hire and deploy about 21,000 helpers. Maryland expects a total of 400 staffers. This is from the Health Insurance News. As the state health insurance exchanges are taking shape with only a few months before their release into the marketplace, states are finding it hard to locate enough potential navigators or a guide to the exchange. As many as 30 million residents without health insurance will enroll in exchanges nationwide. Because the products are brand new, numerous, potentially confusing, the government requires each exchange to staff these guides to the plans. So what are we getting ourselves into? We're getting ourselves into a tar baby. Well, what kind of information is going to be collected? Verification processes. Try this one on for size. If an enrollee for whom advance payments of the premium tax are made or who is receiving cost-sharing reduction notifies the exchange that he or she has changed employers, the exchange must transmit the enrollee's name and taxpayer identification number to HHS. You change a job, and Washington knows about it. They collect your Social Security number. They collect your income tax information. They collect your health insurance. All goes into this database. I think it goes to what the good gentleman from 3 was saying, or 5. So what's the rush? One of the good provisions in this bill, or in this law, is that we do have a choice. And the choice is that we can wait and let the federal government see if it can run its program and pull it off. Why should we be the whipping post? Why should we be the enforcer? Why should we take the risk? CFR 155-106 says that a state seeking to approval of its exchange later than January 1, 2013, which means there's no time limit on it. It just says if you want to get approved after January 1, 2013, what do? Well, you do what we've already done, submit a blueprint. Number 2, you have a 12-month period to go through operational readiness. And then finally, you develop a plan jointly with HHS to facilitate the transition. Why are we rushing headlong into this? Once we're in the tar, baby, we won't get out. Now, you should have a document on your desk that I handed out. It's flexible exchange options for states. This comes from the blueprint that the federal government requires. And there's a 3-page chart there. It summarizes all of the things that an exchange has to do. If you see under state-based exchange, all of the X's, we're responsible for all that stuff. I even forgot to talk about the consumer stakeholder engagement and support. I think that's a good one to talk about. If you go down this list, it matches up with a lot of things in the CFR here. But let's see here. Stakeholder consultation, 155.130. The exchange must regularly consult on an ongoing basis. What's that mean? Regularly consult on an ongoing basis with the following stakeholders: educated healthcare consumers who are enrolled in qualified health plans. That's consumers, I guess. How do they do that? Maybe through their survey. Individuals and entities with experience in facilitating enrollment health coverage. Advocates for enrolling hard-to-reach populations, which include individuals with mental health or substance abuse disorder, small business and self-employed individuals, state Medicaid and CHIP agencies. And here's a kicker: federally recognized tribes defined in the federally recognized Indian Tribe List Act. So we're responsible for that too. Public health experts, health care providers, large employers, health insurance issuers, agents and brokers. Exchange is responsible for regularly consulting on an ongoing basis with all of those groups. So anyway, back to the chart. If you look at the front page, there's 3 columns: state-based exchange, state partnership exchange, federally facilitated exchange. We've talked a lot about the 2 polar ends. Federally facilitated exchange, which is the default if there's no state-based exchange, and the state-based exchange, which is what we're looking at in House Bill 248. There's not really been much discussion by anybody about state partnership exchange. Well, what is that? It's still a federally operated exchange. But if you look at the column in the middle, it allows the state to do a few things. Under 4.0, plan management, it gives the state the authority over regulating the qualified health plans, which is really what we want. If we want to have control we want to be able to control the qualified health plans and not have to wait from somebody in Seattle or Washington to approve a plan. But, and then we have to do the related technology to that interface. What we don't have to do, we don't have to do any of the other stuff, all of the tribal consultations, outreach, call center, internet website, navigators, and take the risk of the uncertainty of that. Why hasn't that been discussed? If we had a partnership exchange, and that sounds bad, I know, because I don't think any of us really want to be in partnership with the federal government in this type of thing. But if you can get past the name, there's a couple of things to be cognizant of. Number one, the oversight for the quality health plans would be with the Department of Insurance. That gives us the direct oversight that we want. Second, we wouldn't face the risks that are entailed in all of the other parts of the exchange. Wouldn't be responsible for enforcement of tax laws, of gathering information and securing it. And we may say, well, we want that. We want to have control over that. The fact of the matter is, as has been said by a good gentleman from 14 who's here not right now, but there is a certain benefit to economy of scale. During the presentations during the summer, we heard from a couple of partnership states. One of them was Delaware, and they did an interesting analysis, and their analysis was that the least expensive per unit for an applicant would be a state-based exchange because of the economy of scales. Next would be a partnership exchange. It would cost a little more. And finally, the most expensive would be a state-based exchange. Delaware opted to go with a partnership because of the lower cost and the opportunity to have control over those quality health care plans. Another advantage of a partnership exchange, if we're going to have one, if we're going to have an exchange with the state involvement, we're not so deep into it. We can get out if it looks like we really don't want to go down this road. Secondly, it preserves the legal remedies that our small business owners have potentially through the Oklahoma lawsuit, because this is still a federal exchange. If we go down the state-based exchange route, you lose, you give up that argument. I realize that that's been covered somewhat in amendment to the bill, and that's good. That's a positive thing. But still, this partnership model really wasn't discussed very seriously, and perhaps it should be. Well, I'm just going to close here by saying that nothing in government comes out as simply and as uncomplicated as we think it's going to be. And we know going into this it's complicated. And you think it's going to get any better? I know when I try lawsuits in court, and I get a client that comes into me, and they give me their story, and I say, oh, that's good. Yeah, sounds like a good case. Well, when I get into it, there's always more to the story, isn't there? And that's the same in life. It's the same with this exchange. We think it's complicated now. We haven't seen the beginning of it. It's a tar baby. Idaho has been in the forefront of resisting federal encroachment, and now we're turning to embrace it. They need us to implement their program, and I'm not inclined, and I'm not going to support it. Thank you.